So just starting out a picture with, showing something instead of my title slide. This is my kitty cat, Loki. He's just in the mirror there, so I just thought it was kind of a neat little picture. So that's Loki. This lecture is liver masses. There are me and Dr. Hughes' websites. If you have so many questions, my Twitter things, which I haven't been doing lately, but I'm going to start doing again sometime, hopefully very soon. And like I said, just remember, I'm a forensic pathologist, so I have a very broad overview of pathology, but I have a very strong interest in general and organ pathology and in teaching medical students. And so I hope I give kind of a more broad overview and not just specialized in some areas and stuff like that. So I hope for the students. If you would pause, read the disclaimers, make sure they do not apply to you. If they do apply to you, do not watch the lecture. Same thing, pause, read the third disclaimer, make sure it does not apply to you, and then if it doesn't, go ahead and watch the lecture. The last one, just in case you're interested in my teaching style, different thought processes on stuff, then view my introductory presentation. Here's my list of references. These are all great books, but these are ones I'm using to make up the lectures. So I start out every lecture with a question. The idea being that you have not had this information before. You read the question, you try and think through it, and then it kind of makes you pay better attention as you go through the lecture, is what they say. And at the end, we'll discuss it, and this has been shown to increase retention. Okay, so the first liver mass we'll talk about is focal nodular hyperplasia. So basically, this usually occurs in young to middle age. We see them at autopsy not too infrequently. Grossly, they're very characteristic. They're a well-demarcated nodule because they're benign, and they have a central scar. And then microscopically, they just look like cirrhosis. They have nodules of hepatocytes divided by little fibrous septa in that. So the way I remember focal nodular hyperplasia, what it looks like is I just remember focal cirrhosis. And what they say it's due to is a focal abnormality in the blood supply. So if you kind of look at cirrhosis as basically the liver's generalized way of responding to injury, if you have a focal abnormality in a blood supply, that would only affect a part of it, so creating a mass, and could cause something like cirrhosis where the body's responding to the injury that would cause by the ischemia. That's just kind of my way of thinking about it, remembering it. So this is focal nodular hyperplasia. In the top left is a nodule. This one actually has a really good central fiber or central scar. And if you have or have not done renal yet, the oncocytomas have a central scar. And so microscopically to the right of it, I hope I just said that right. If not, we'll get on the renal. Sorry. So the bottom right of it, you can see a nodule there, but I thought that really wasn't the best look at it. So I put a closer-up one to the left. So this is a closer-up, and if you look at it, it looks just like cirrhosis. You see fibrous bands throughout it, and separating between them, you see nodules of hepatocytes. So it looks just like it. One differential for a younger person with a liver nodule is focal nodular hyperplasia versus hepatic adenoma. So hepatic adenoma would just be hepatocytes. It wouldn't have the fibrous component to it. So that's why you kind of tell them apart. Cavernous hemangioma, these are also very common. We see these autopsy frequently, and you'll see a single nodule or sometimes a couple of them. Usually they're pretty small, like less than a centimeter, but they can be bigger than that. I've seen one that was like 5 or 6 or 7 centimeters or larger. So cavernous hemangioma, basically what you have is you have fibrous, variable size fibrous septa that form spaces, the caverns, and then those are filled with red blood cells. So the top left of it is what it looks like grossly, and if you push down, it'd be spongy because it's basically mostly just red blood cells in that with little intervening tissue. And then to the right of it, it shows what it looks like microscopically. You can see the lighter pink are the fibrous areas, and then creating these variably sized spaces that are filled with red blood cells. So it's not in, as far as I can see, in Robbins, but I think this is a really good one to know, something called a von Meyenberg complex versus a biliary, von Meyenberg complex, which is also called a biliary hamartoma, versus a bile duct adenoma. The reason I'm putting these in there is these are actually pretty common. So these are common incidental findings that you might see during surgery, and you see a little white nodule in the liver, you're going to be concerned about the possibility of metastasis, I would assume, and you're going to have it probably take a section of it and give it to pathologist, do a frozen section on. And so these are one of these. These can mimic a metastatic adenocarcinoma, and they're pretty common. That's why I put them in there. So top right, you can see is the bile duct adenoma. Bottom of it, you can see it. So basically, it's like a nodule formed by a proliferation of a whole bunch of little bile ducts, but there's no bile associated with it. In comparison, in the von Meyenberg complex, which down there to the left of it, inside that box, you see a whole bunch of little white spots. Those are all von Meyenberg complexes. So this one had quite a few of them. Top left, the black arrows show the complexes, and the bottom right shows a more close-up. And so you can see the black arrows are showing bile. So a bile duct adenoma won't have bile, and a von Meyenberg complex will. And like I said, I don't see these in robins unless I missed them. But they are commonly seen at surgery and stuff like that. And with CT and imaging getting better and better and better all the time, there's always a good chance we might start seeing more of them. So just thought I'd include those. So hepatocellular adenoma, once again, it's a nodule. So a nodule, obviously, especially benign, can be asymptomatic, but I like the one here with it could be associated with pain, and that can be if it grows and pushes on the liver capsule, that could cause pain. Or anytime a mass has hemorrhage or necrosis, and hemorrhage or necrosis does not have to imply malignancy, then it could potentially cause pain too. So this one's commonly associated with sex hormone exposure, so oral contraceptives or anabolic steroids. And then it does have a low to, it says high possibility of malignant transformation. So some of them are very low, some of them can be fairly high, and it's based upon its molecular profile is what it says. So grossly, you'll see a nodule, and microscopically a proliferation of hepatocytes. So to the left of it, to the right of it, that you can see basically from 12 o'clock to 6 o'clock, there's a distinguishing line. To the left is more eosinophilic than to the right. To the right is the adenoma, and then I did a close-up on the bottom right. So you can see basically there's just essentially just hepatocytes in there. So this is hepatocyte adenoma. So this is from Billings. Every once in a while we get wildlife out there. There are some groups of turkeys, and I don't know the name for a group of turkeys, sorry. But sometimes we wander out there. The good thing is we usually people stop for them and let them pass by. One time I saw a mom duck leading her little ducklings, and everybody stopped and let them cross the road. Okay, so hepatocellular carcinoma is associated with cirrhosis, and so especially with hepatitis C, since hepatitis C is about 50% of people with hepatitis C can get cirrhosis of the liver, although now with treatment for it, it's probably lesser than that. So one thing you got to consider about hepatocellular, as with a lot of these GI malignancies, different parts of the world that have higher incidences of things like liver fluke, stuff like that, are going to have and different diets are going to have oftentimes different, markedly different incidences of these tumors than you might see in the United States. It is in Southeast Asia, it says it's usually around 20 to 40 years of age. In the United States, more around 60 years of age, and almost all have cirrhosis. So my understanding is people with non-alcoholic fatty liver disease can develop hepatocellular carcinoma without having underlying cirrhosis. But for the most part, every other adult would. And then kids get different types of carcinomas and stuff like that, and they don't have to have cirrhosis. So other risk factors, non-alcoholic fatty liver disease, as mentioned, aflatoxin, alcohol. So alcohol can lead to cirrhosis, and then cirrhosis is the risk factor. Any other inherited diseases, so alpha-1 antitrypsin, hemochromatosis, potentially things like that. So the mutation you see is a gain of function in beta-catenin or a loss of function in p53. So the beta-catenin would promote cell cycle, and p53 normally protects against it. So if you lose the p53, you don't have the protection against carrying forward mutations and stuff like that. Precursor, as we just described, hepatic adenoma, can be a precursor to it, depending upon the molecular profile of the tumor. Can be low or high, and then sometimes it just says you can have dysplastic nodules. These can be low or high grade, but anytime you have dysplasia can go on to carcinoma. So grossly, they can be one nodule, unifocal. As you see in the picture there, the one right in the center is slightly green. That is a hepatocellular carcinoma occurring in the background of cirrhosis of the liver. You can also see multiple nodules, and it says these are oftentimes due to intrahepatic metastases, and also it could just occur diffusely. Microscopically, it'll be highly variable. It can be well differentiated, meaning it looks really well like hepatocytes, to anaplastic, where it's hard to even tell what it is. And then the neat thing about it is it can have normal features of hepatocytes, as is appropriate. So the more well differentiated it is, the more likely it is to behave like normal hepatocytes. And so you can see things like I've seen quite a few hepatocellular carcinomas at autopsy. You can see things like bile production. I've seen Mallory's hyaline. I've seen steatosis, everything like that. So some of the normal stuff that you see, but of course the cells are going to look more dysplastic, neoplastic. So these two are not the best, but I think if you look at them, you'll see, and then there's a better one later on. So the black line shows the distinction between the normal liver and the hepatocellular. The black star on each side shows the hepatocellular. So you can see this one's pretty well differentiated. The neoplastic cells look pretty much like normal hepatocytes, but I hope you can appreciate to the bottom right, the nuclei are bigger and a little bit darker, and that's the neoplastic side. And like I said, there's a better one later. But I thought this would just help you understand kind of that range of how differentiated they can be from, like that one was pretty well differentiated, the one that might be, hard to even tell it's liver. So this was hepatocellular carcinoma. Bottom right, you can see it. You can see the liver there. They had micronodular cirrhosis. And then the red part, that's the tumor. The top left is it. And this is actually kind of an interesting one. It actually eroded through the capsule liver and then bled into the peritoneal cavity. So this person actually died from a hemoperitoneum secondary to a ruptured hepatocellular carcinoma due to cirrhosis of the liver. So this is why I talked about that. Hopefully it's a little bit better. Top left, you can see to the left side of it is the cirrhosis. To the right side of it, those nodules is the hepatocellular carcinoma. And then, this is flipped backwards, but on the bottom right, the black arrow is the tumor and the yellow arrow is the normal hepatocytes or the cirrhotic area. So if you look at the bottom left, you can see the black arrow. You can see the nuclei are much easier to see. They're much larger. They're more hyperchromatic. To the right of it, they're much smaller, more indistinct, and everything like that. So that once again, you can see here the difference between the two. The bottom left is hepatocellular carcinoma. And then they can occasionally be diffuse, more throughout. So unifocal, multifocal, and then they can be diffuse as well. So this one, that you can see the neoplasm takes up, probably 60% of that liver. Another one that you can see in the liver associated also with cirrhosis is cholangiocarcinoma. This one's also associated with liver flukes. So obviously in the United States, liver flukes are not a main risk factor because we don't see it that much, but other countries can see quite a bit. Primary sclerosing cholangitis as well, so any type of inflammation. So cholangiocarcinoma is adenocarcinoma type based upon the cholangios, so the bile ducts, and so primary sclerosing cholangitis and inflammation of it could associate with it. Liver stones and then hepatitis B and hepatitis C are also associated with this one. I've seen one case at least where a person had both hepatocellular and cholangiocarcinoma. So cholangiocarcinomas could be expected. It's going to form what look like little glands, little ducts and stuff like that. So here you can see on both sides the kind of ductular / glandular differentiation where you see a ring of the neoplastic cells with the lumen in between, and that. So when I was making up the lectures, I had a couple liver things. I did this too at the beginning with the appendix and stuff, but they didn't really fit anything else, but I decided to include them. So to the top left, this is a common condition, Fitzhugh-Curtis syndrome. This is perihepatitis. The yellow arrow shows basically fibrous adhesions between the diaphragm and the liver, so kind of what they describe as violin strings. And so this is seen in people with pelvic inflammatory disease. So this is a really good one to know when you're on a rotation with OB-GYN. They told me this. They said, yeah, if they turn the laparoscope up toward the liver, you can get this one right. And actually, I was watching a surgery when I was a medical student. They turned it up toward the liver, and there it was. And they said, you know what that is? I said, Fitzhugh-Curtis. So I was right. So good one to know. We see it at autopsy not too infrequently, actually. Bottom right, this is a multicystic liver. So you can see with like autosomal dominant polycystic kidney disease, it can affect other organs as well. One is the liver. And so throughout it, you can see all the translucent places. That's the cysts. And then this is just showing you, this is sarcoidosis of the liver. Top left looks a little vaguely like cirrhosis, but it's not. At the bottom right, all the lighter pink you see is all the fibrosis. And then you can see speckled through there multinucleated giant cells, and closer up you see granulomas. So you can see sarcoidosis. Okay, so the question, so pause and then we'll answer it. So a 53-year-old male with a history of cirrhosis of the liver associated with alcohol use and chronic hepatitis C infections involved in a motor vehicle accident. As part of his emergency room evaluation, he has a CT scan of the abdomen to check for injuries to internal organs. The liver is nodular and the right lobe is a 6.8 centimeter mass identified. Of the following, what is the most likely diagnosis? Answer is hepatocellular carcinoma. So since he has cirrhosis and since he has a nodule, the best one would be hepatocellular. So I just threw cholestoma in there. Obviously, that's in the ear, so you're not going to see that. Metastatic renal cell. Actually, with cirrhosis, I've been told that it's harder to see metastases. Well, I mean, you can still see them, sorry. It's harder for them to occur. And the reason is because the background on which those cells have to deposit and then grow is not the best with the fibrosis and stuff that you normally see. You could see lymphoma in the liver, you could see angiosarcoma, but they'd be much, much less common in somebody who has cirrhosis with a single nodule. The best choice is hepatocellular. And then at the end, like I said, use reflection. This is in Make It Stick, where a medical student used this and went from bottom of their class, top of their class. I always tell you, sorry, there's a lot of repetition on each one, but I have to assume anybody watching the lecture is only watching this one. And what you do is I want you to pause, think back through the lecture, and think of, okay, what are 5 important points that he made? And I hope I made 5 important points. And this is a really good way to help remember the material. And like I said, I used it in college without knowing about it, what it was. Didn't think about it in medical school, but now I've started using it now again. So this is why I don't have a summary slide. I want you to summarize for yourself so you better learn the material and remember it better. Okay, so this is my kitty cat, Moach. She's really tired right now. She thinks this lecture was kind of boring and stuff, but I'm hoping you got more out of it than my kitty cat did. So I hope you've learned something from watching the lecture, and thank you.